So I'll let Anna take over in a second, but just as she's getting set up, the purpose of this very informal discussion came about from Anna's interests and observations about the different ways in which people come into pediatric neurocritical care. A number of the people on this call, I see Jessica, Kerry, myself, Courtney, got interested in this field when already practicing and somewhat established in our fields variously in critical care and neurology. But as the field has now become a field with different ways of developing a distinct career path, there are numerous people, I'm sure the more senior of us have all been asked, how do I go about training in the right way that meets my clinical and research interests? And those are some of the questions that Anna wanted to foster in today's discussion. So with that context, Anna, I'm going to hand this meeting over to you.
All right, great. Thank you. Thanks so much, everyone, for joining us today. We do have, I think more people will be joining shortly. So I did create a database of trainees in pediatric neurocritical care stemming from child neurology to PICU and people, trainees in the pediatric neurocritical care fellowships. So I know many of them might be joining today. And so the overall goal, as Dr. Wainwright said, of today's panel is just to introduce some of the pathways that you all have taken to reach pediatric neurocritical care faculty and how you're balancing research with clinical duties. I think that discussion might be very helpful for those of us who are in the early stages of training. With that being said, I will share my screen just to introduce the panelists. We thank everyone for joining our panel today. We have amazing speakers from all sorts of backgrounds, from neurology training to PICU training. Many of you are doing exceptional work in pediatric neurocritical care research. I think we can start by just having small introductions. So if you are a panelist, if you don't mind, maybe unmuting yourself and giving us a little bit of a history of your journey into pediatric neurocritical care.
Thank you, Anna, for getting us all together to talk about this topic. I consider myself on the more junior side, so I'm very curious to hear what more senior people have to say. But the way I got into neurocritical care was actually a series of fortunate events and powerful mentors along my path. I never imagined myself being interested in this field because I didn't know it existed, actually, when I started my training. And it actually began in Peds residency when I became interested in critical care through a really powerful PICU attending who stoked my interest in critical care medicine. And because of her influence on my life and her mentorship, I decided to pursue critical care training. And I finished a PICU fellowship at Columbia. And during my time there, I had another really powerful mentor, our current chief of critical care medicine, Steve Kearney, and working with him in his lab looking at neurogenesis after traumatic brain injury. That got me down the pathway of thinking, wow, there's actually a way you can subspecialize within critical care. And late in my PICU training, I discovered Dr. Wainwright's fellowship, and I applied, and he accepted me, and under his mentorship and vision for what neurocritical care can be for a PICU-trained person, I now have my dream job, and I'm doing the things I do, such as the program director here and clinical time in PICU and neurocritical care.
Great. Thank you so much. Maybe we can go next to Dr. Robertson, if you could give us a little bit of your backgrounds.
Sure. Well, Thanks for inviting us, Anna. This should be fun. So Mark and Steve Kearney and I all probably trained about the same time, and used to see Mark at these critical care meetings, when I was early in PICU. So we had a shared interest even back then, but it wasn't really officially, Peds neurocritical care at least wasn't officially a field yet. So I got interested in PICU during my residency in North Carolina. I really liked the ICU environment. And then in my fellowship in Pittsburgh in Peds critical care, I was really lucky to come across an amazing mentor in Pat Kohanic, who convinced me that I really needed to do basic science, animal research in pediatric TBI, and got me set up and started with that, and just instilled a passion in that. So when I first came out, I would not have called myself a neurointensivist. I was just a general PICU faculty at University of Maryland, but doing Peds neurocritical care relevant research and the bench. Then transferred to Hopkins about 10 years later, where I was actually able to do some clinical research in pediatric TBI, and where I would really call myself now a true neurointensivist. I was running the Peds neurocritical care program as it got started there about 8 years ago, and moving along that path. So I've had a neuro interest all along. I'm probably more officially a neurointensivist in the last decade at Hopkins or so. So glad to be here.
Thank you so much. Next, we can go to Dr. Kirshen.
Hi, thank you, Anna. Thank you for the opportunity to participate with everybody. I started out as a child neurologist. I matched out of medical school into the 5-year Peds Neuro program. And as I went through my child neurology fellowship, I realized that what I really loved was the higher acuity acute brain injured patients in the ICU, and rolled my eyes and dreaded going to clinic every time I had to see general neurology patients. And I actually tried really hard when I finished fellowship to be essentially what a neurocritical care consult attending would be now, where I would do all of my clinical time on an inpatient consult service, servicing patients in the ICU. And I was basically told by the leadership at that point in time that I couldn't do it because I couldn't support my own salary doing that, given the amount that you got paid for consults versus seeing patients in clinic. And so I realized at that point in time that if I really wanted to be caring for the patients that I wanted to care for, that I needed to do it from the PICU side. So I looked into doing an adult neurocritical care fellowship or PICU, and ultimately decided to do a PICU fellowship. And after completing a PICU fellowship, was part of starting the neurocritical care program with Alexis and others here at CHOP. And now I do all of my clinical time in the PICU, as well as participate in our neurocritical care program.
Awesome, great. Thank you so much. And I see Dr. Pineda just joined us. Good morning.
Good morning, thank you.
Good morning. We're just doing short introductions and kind of your background and how you ended up in neurocritical care.
Oh, sure. I guess dating myself, my interest in neurocritical care began when there was no talk about training in it. So during fellowship I did training in pediatrics critical care, and year where clinically I did cardiac critical care, to be honest, mainly because of my interest in cardiopulmonary bypass and brain injury clinically. At the same time, I was working in the lab with David Warner, coincidentally, the same lab where Mark Wainwright did his basic science training. And it was a good experience. It's called the Multidisciplinary Neuroprotection Laboratories. And you found yourself, working at the bench next to Mark, and then on the other side was Jay Wellens, who is now Chief of Pediatric Neurosurgery at Vanderbilt. Anesthesiologist, we developed a model for bypass in rats and brain injury. It was a lot of fun. Then I got my first faculty job at the University of Florida, mainly to work with Ron Hayes in traumatic brain injury at the McKnight Brain Institute. And after a couple of years with working in the lab with rodents and in adults, which I guess maybe it's not funny where I say the best model of pediatric TBI in the lab is adult TBI. So I did some studies in adults with TBI and published a couple of papers, but then became clear that I wanted to focus in pediatric neurocritical care and was recruited to Washington University in St. Louis to develop a program there, and we did run it for about 10 years, and then I moved here to LA to become a division chief with a neurocritical care program as one item on the wish list moving forward. So still linked to neurocritical care in many ways, but kind of like with a more diverse portfolio of interest.
Great, thank you so much. Next we can go to Dr. Wainwright. If you could give us a little bit of your background.
Yeah, briefly, it's a little circuitous. I was the first person in my family to go to university. I actually didn't know what a university was because no one had ever been to one. So I actually trained as an undergraduate as a philosopher, and then immigrated to this country with the rather naive idea of going to medical school. So I worked nights as a doorman and took pre-med classes. That got me into medical school. And there I first thought of being a child psychiatrist, then I got interested in neurology. And during child neurology residency, where I trained, we did a lot of ICU. There was a neurocritical care unit at Duke. And as the child neurology resident, you ran that unit. So I did a year as Peds intern. And a month later, I was on call at night on my own in a 12-bed adult neuro ICU, and I really liked it. And so once I got a faculty job in Chicago, I decided I would see all the PICU consults. And so I just started seeing patients, and then gradually I was fortunate to get really good colleagues like Sue and others, and what became a one-person consult service just evolved into a program. So rather not well planned out, just taking opportunities, following your interests, and with a lot of luck and some great colleagues.
Okay, thank you so much. And last but not least, we'll go to Dr. Marina Borowinko.
Hi all, thank you for having me here today. What an interesting idea for a discussion, and really forward thinking. I have to congratulate you. So I would say that my background is not too dissimilar from what you've heard here, in that when I finished my training, also there was no formal program in my region for neurocritical care training. That being said, I trained under Jose Suarez on the adult neurocritical care side, where it was very formalized and very rigorous program, and learned so much from him about being mentored and mentoring and how to forward science in our clinical realm, and what a great role model he was to me, and an inspiration, so that as I transitioned to attending at Texas Children's Hospital at Baylor, I was the first dedicated 100% neurocritical care attending there. And the consult level was, I would say numbers was around like 20 per day. And I don't know what, Matt, it was like at your institution, but I was the most profitable attending on the entire service. So yeah, I think there was plenty to go around and support my salary. You get those reports every month from the bean counters telling you, how are you doing with your RVUs? And that was never an issue. The issue was really having enough time to implement rigorous objective markers of brain function and think through each patient, which were so unique, I would say, even compared to the adult side. And it was just so very challenging in that way. And because of those feelings of wanting to improve our objectivity of our markers of brain function in children with neurocritical care problems, I started a research program involving resting state functional MRI during my residency, trained from the folks at Oxford on that, and implemented it in a research program and a clinical program involved with children with epilepsy and the ICU. And then from there, just the career took off and mentoring others. And now I'm the neurocritical care program director here at Phoenix Children's.
Great, thank you so much. Thank you all for these introductions. One of the questions that I think usually comes up, especially early in training, is as you're in residency and fellowship and trying to build a career in academia, is how you balance research with all your clinical duties as a fellow and resident. I know these days many fellowships do include protected research time to encourage scholarly activity, but I was wondering if you have, if you can share your experience and some tips on how you've managed to do that, especially early on in your career.
I might take a stab at the question. Certainly at the program I was at, we were at the Texas Children's, we were very RVU driven, and so it would be a difficult environment to start research, and that was not an uncommon issue, I think, across the entire country. But I felt especially so at my institution, at least at the time. And I would say negotiation skills are critical, and relying on finding a way within the system that you're at to fill your time in on service while you're doing that other activity. So, I mean, for me though, that meant like taking call nights loaded up front in one period of time and then having other time off. But I would say that you ask a very good question, and certainly applying for scholarships that are available to trainees can help a lot with the leadership agreeing to being able to let such protected time happen, especially early in training and early in careers.
So I'd be interested in the opinion of Courtney on this as well from another institution, but as a primary PICU-based person, being a junior faculty member, I actually find it a very suitable field to get your research up and going, because the clinical time that you have is blocked out, and it's often very limited. Most of us do somewhere between like 8 and 12 weeks a year, and then other than your call nights, the rest of your time you can devote to research. And I recognize those weeks can be variable depending on what your institutional requirements are and how much funding you have, et cetera. But it's actually a great model in order to be able to start your research career.
Yeah, Matt, I think that's a great point. The ICU does probably lend itself a little easier to that than perhaps, you know, having clinics as a neurologist that really start to be weekly no matter what and intrude upon your time, as well as your inpatient service. I will say that, so I think the other key to my success was most certainly, fantastic mentoring from Dr. Kohanek at Pittsburgh, and then transitioned to Gary Fiscom at University of Maryland. I just couldn't say, you know, that's critical to have people to advocate for protected time for your academic pursuits is key, and to have that person talking to your department chair or leadership to get you more protected time. At the time when I was doing it, the full-time load was about 13 weeks, and we only had four or five of us, so that our call nights were a couple a week, and we didn't have fellows, so we were in-house a lot. And at the time it felt actually a little harder. So one of the keys to my success was certainly getting a K grant. Mine was through NINDS, and applying. Gary told me about that very early out of fellowship. He's like, you got a couple papers from fellowship. I think you're ready. I was like, I'm not ready. But I applied, and after a few attempts, you know, was able to get a K08 to buy myself out of some of that, those weeks and some of those calls. And that really moved me along quite nicely. So I'd say that that's definitely another addition if you feel like your clinical burden is heavy. And I remember going to the NINDS-K training stuff, and at the time when I compared my ICU schedule to the neurologist ICU schedule, mine was pretty hard. But I think depending on your, you know, how it falls, you can easily carve out time in a PICU block. So
I'll comment a bit from the neurology side and just follow up on what Courtney said. I think while there are differences, the need for a supportive mentor or supportive chair, a division head, is really key. The hospital administrations, you know, always focused on RVUs and get clinical time, and that's worse now under COVID and budget cuts. But the chair or your division head needs to be able to provide you at that early stage of your career with some protection and flexibility. So your impact and value to your program is not measured just by RVUs. For the neurologist, that's a challenge, because to do that, you need to have outpatient clinics. On the other hand, that's also an opportunity, because I don't need to tell this audience just how important it is to be able to measure long-term impact, and actually seeing the patients who you saw in the ICU critically ill coming back and recovering, even if they're not fully recovered, seeing them with their families in the outpatient setting is really rewarding. So I'd say I'd reinforce Courtney's point that is common to neurologists too. You need a supportive mentor and program leader. The other practical way of addressing this for neurologists is some people, if they're interested in epilepsy as well, doing an epilepsy or neurophysiology 1-year fellowship that allows you to read EEGs is a very efficient way of generating revenue and RVUs. You don't have to be an epileptologist to do that. So that's actually quite a practical pathway for the neurologist too.
It's Jose here, just trying to add what Matt, Kearney, and Mark said. You know, I would say that the first 3 to 5 years out of fellowship are the most crucial. And I think you guys touch on the most important points. You know, balancing clinical time or research time, or balancing work and life is kind of an interesting concept, right? And it has a lot to do with a concept called the power of full engagement, right? So if you are trying to do your research while you're clinical, you're not going to do either well, and much less enjoy it, right? So the concept of protected time, I think, ties to the concept of institutional momentum, right? If there is commitment, you have a good mentor, the other component is the time, and it has to be truly protected time, right? In fact, when we review K applications, whether it be a K08 or a KL2 or K12 these days, if the letter doesn't say, you know, this person will be protected regardless of whether she gets the award next year, they drop 1 tier right away. Because the chances of getting it are, you know, 15, 25%, and are they committed to this person, right? So if she doesn't get the award, means you're not going to be protected. So that commitment is important for 3 to 5 years. And then, like Mark said, you know, enjoying your clinical time and also using it as a way to assess the significance of the work that you're doing in your research, right? Some people will say, if you know that what you're working on in your research will not have any chance of changing clinical practice in the next 5 to 10 years, it is going to die eventually as a line of research, right? So being at the bedside and keeping your eye and your finger on the pulse of what is relevant makes sure that the ideas you're working on in the lab are linked to eventually being translated to the bedside. Otherwise, why are you doing it?
So some great points. Thank you. Some of you alluded to the process of getting K awards and gave us some tips already. But I was hoping to hear a little bit more about your process in getting early grants and you know, how your work during fellowship impacts your ability to get the K awards. It sounds like Dr. Robertson mentioned, you know, she had a couple papers from fellowship, and that was in some ways, with good mentorship, sufficient to bring you up to the same level to compete for the K grants. As I was wondering if there were any other comments or tips from our audience here regarding early career grants.
Well, a couple of things that come up are focus, right? Even though it's early in your career, you have to be able to demonstrate that you already have a line of focus on what you're doing. And like Courtney said, you know, a paper or two in fellowship that are not in urinary tract infections, right, will look good in a neurocritical care career development application. You're building your story already. Second is the mentor, and to be honest, I think Courtney will agree, those of us who were lucky enough to get early grants, he was all the mentor, right? I mean, that's really 90% of it. And after that, follow the bouncy ball that your mentor tells you to follow. But that is crucial. And then when it's competitive, which is the case most of the time, to be able to demonstrate that you and your mentor are already working together, ideally with a joint manuscript or something like that.
I might add a counterpoint that if you have a brilliant idea or you feel it's brilliant, go with it, even if it's a long haul. That's how we'll forward our field.
Right. I'm glad you mentioned that, Marina, because if you look at innovation and the things that have moved the field forward, and then you ask how many of them were sponsored by NIH, you will be surprised.
I'll just add to that. I don't think this is all about this theme of doing something that's important, doing something that's exciting to you, and advancing your field. I think those are really important. And I don't think this should all be about K awards. This is an emerging field. It's a hybrid of neurology and critical care. So someone trying to make an academic career in pediatric neurocritical care already has that challenge, and then you superimpose on that trying to get a faculty position as a clinician scientist with 80% protected time moving towards a K award. That's a lot of barriers to overcome, and you don't need to think, I don't think many people have a lot to contribute, do contribute a lot to this field without the K award. I don't think you're trying to imply that, but there are people on this call who are doing that too. And I think that's probably also important for us to emphasize. Is by definition now in Peds, this is a career that can only be practiced at academic centers. And there's many ways in which you can advance the field and do things that are important without be thinking in terms of NIH funding.
I want to say that I personally have not been able to go down the K path, and I've looked to working in research groups and collaboratives to find mentorship and to find other like-minded people with interests similar to my own. And through that, I've been able to get involved in NIH-funded projects as a site PI. I've also gotten publications out of that are in press or have been accepted for publication. And through different rabbit holes that way, I've now gotten myself very involved in the acute myelitis community and have gotten a few $100,000 for public outreach and education in the community. And so the idea of mentorship and opportunity and taking things as they come, I think we've all spoken to that, and it's still true for me.
And the other thing I'll add to second what Sue said, and I've had success in similar ways through lots of collaborations, is remember that not all grants need to come from the NIH, that there are many funding mechanisms that are either through foundations or societies, and even many institutions have internal grants that may not be career development grants, but may give you $10,000 or $20,000 in order to get a project started so that you have enough preliminary data to apply for a larger grant. Many of the societies like the American Academy of Neurology, I got a grant through the Neurocritical Care Society, Child Neurology Society, SCCM, they all have small, either early stage career development or just pilot grants in order to get your ideas started, can be very fruitful. And that also is very helpful with networking in terms of getting to know other people who work in a similar field. The other thing that I'll say is that even with very little funding, you can still do a lot of research in Peds neurocritical care if you're willing to put in the time, because a lot of the research that we do in clinical domains is really retrospective, case reviews, cohort studies. Our field is not necessarily at the level of randomized controlled trials for things yet. So if you find a few like-minded people at various institutions, you can put together a case series of whatever your disease entity is by doing chart reviews at 2 or 3 institutions and have 50 patients, and we can learn something valuable about disease processes that way. And then that can help spin off other parts of your research career as well.
And I might add to that that recently there's been a shift toward big data in data mining and data consortiums that that can take, I mean, this is really just the beginning. If we think, oh, we're going to have one question answered by an extremely expensive, time-consuming, randomized controlled trial, what could we learn from pulling all of our data together and mining those databases could be highly more fruitful for so many reasons for us, and I think moving our field forward, and really something that you youngsters need to get into and become experts at.
And I was just going to add one point off of what Mark said. Of course, the K pathway is nice for protected career development, but there are lots of options. And since we're on the call as the Peds section of the Neurocritical Care Society, we'll also mention the Peds Neurocritical Care Research Group, which most of these names on the call I can see have been involved with our organization. But we're sort of not necessarily a subgroup of NCS, but an associated group of the Neurocritical Care Society. And I see a lot of junior faculty that have come to that also as a way of building, meeting like-minded people. We at our PNCRG meetings always welcome junior faculty to present their research ideas, to get feedback from leaders in the field. I think many of you have done that over the years, and to also start to build collaborations like Sue was talking about, where you start to network with others and find people like the TCD working group. Carrie, I see Carrie on the call, you know, so making those matches where you can start to really promote your research that way. So I think the consortium or research group idea is great, and PNCRG is just one of the, I think, a great organization in that way.
So this is manuscript that somebody shared with me many years ago, and Deborah Cook, you guys will recognize the name, John Marshall, the Canadian Critical Care Trials Group. We actually modeled the Pediatric Neurocritical Care Research Group at the end based on this philosophy, and some people will agree, others won't, that the Canadian Critical Care Trials Group has been the group that has moved adult neurocritical care the most forward with good science. And they describe that here nicely, right? And they describe the, you know, different type of studies that people have been mentioning. And then have this really nice table here that I showed to all my mentees, right? You're at the bedside in the ICU, you're in clinic, you know, and you come up with a question, right? Something you're curious about or something that bothers you, and you say, well, this would be better, right? So that this kind of process is not a recipe by any means, but you start by asking yourself, you know, what is currently known about this question or issue, right? You read the literature. What is our current practice? What are we doing, right? Is this a real problem, or does this happen, you know, once a year? Because that wouldn't be a very fruitful effort, right? For a junior faculty especially. And then basically you start defining the question, the landscape. Marina mentioned big data, right? So that's one way to do it these days. And then you ask yourself, with what I have learned so far from other people's work and my own preliminary data and work, is this feasible? Will this eventually move forward, right? Because again, if it's not going to move forward to this level, it's not going to help patients, right? And that's, I guess, what we want. And ultimately, if it's that good, you end up at the level of a randomized clinical trial, and that means that you have done half of the work, right? Because the other half is actually implementing it with high fidelity and in a sustained way. And this is actually another very fruitful area of research for neurocritical care. Pick, for example, fever, or pick hyperventilation, subclinical status. The list goes on and on and on. But you could argue that there is a fairly decent amount of knowledge already, maybe not a randomized clinical trial, but pretty close. And can we implement these good clinical practices, right? And that has two advantages. One, it may benefit patients right away. And second is preparing the ICU environment for a clinical trial one day that can be done in a better environment, basically, with more chances of success. So I kind of like that framework a lot.
I might just point out that the Oxford Center for Evidence-Based Medicine has a different pathway depending on what your question is. And so to be aware that there would be a different pathway for a diagnostic versus a therapeutic, and if you're thinking about carrying an idea through all the way to clinical applicability, to refer to our evidence-based medicine guidelines depending on what your question is. But this one is pointing out therapeutics, but there would be different pathways for different questions.
Yeah, for predictive models, right, Marina? A lot of people are into predicting this, predicting that.
Or diagnostics, yeah.
Right, and the tripod statement, right, is very important as a consortium, and it basically walks you through how you develop a predictive tool or a diagnostic test for anything. So they're good frameworks, and if you think with that, if you have that in mind when you're writing your grant or planning your next project, it's quite helpful.
We also have Dr. Frankur here online. I was wondering if you can provide a Canadian experience with regards to research pathways and training in pediatric critical care.
You know, it's quite different here in a lot of ways in that there are not very many centers in which you can train. In fact, Toronto, I believe, is the only one with a formal neurocritical care training program, though I think some other programs are trying to start up. So your options are Toronto or the States, at least from a training perspective, from the critical care pathway at least. And in terms of research, it really totally depends on what type of institution you're in, whether you're at sick kids. I think Nicole is on the call and who could give some more information for that. I, for example, am at an academic center, but with few resources and with much less pediatric training compared to a lot of other research paths. So I've really had to depend on my relationships that I developed while doing my neurocritical care fellowship at CHOP. And then, like Sue talked about, PNCRG and getting in through other groups and just trying to latch on early on and see what is available and offering my help as much as possible as well. And, you know, the reality is in some ways, whether I have first author publications or things like that, my career path, honestly, it doesn't affect it here at my center. So I've done that by latching onto other people and offering my help as much as possible and learning as I go and then developing my own path as I go.
Great, thank you. Now maybe we can hear from some of the trainees here on the call. Dr. Neil Munjal is here as well. I don't know if you would like to give kind of your perspective on how you're dealing with, you know, managing research and clinical duties during your fellowship.
There we go. Okay. Hi, everyone. I'm Neil. I am similar to Matt, finishing up my dual training in Pittsburgh. I did my child neurology 5-year combined program here and then decided along the similar perspective to do my 3-year PICU fellowship. I'm just finishing it up now and I'm also doing the T32 program with Pat Kohanek, just like Dr. Robertson. So a lot of similar fields going on in terms of trying to struggle and try to figure that out. So I appreciated all of that input on on this balance, because I think certainly during my PICU fellowship and also during my child neurology fellowship, I think I was struggling a lot with trying to figure out how to balance my clinical and my research duties. I think the T32 has been extremely helpful in doing that. So now that I'm done with my clinical training, I now have this year where I have a fair amount of protected time and hopefully posturing myself towards funded research and also looking for a job in the area of COVID.
I might add something to what Connell, is that how you say your name, was saying about feeling somewhat isolated if you go to a center that's so clinically driven and doesn't have so many colleagues that are similar to you there. One of the resources that could be available to you, which has made a serendipitous, amazing difference in my career, has been thinking of yourself as a project director for the academic resources around you that might be on the university level, say such as bioengineering and computer engineering and such like that, that I cold call deans of departments at local universities, and it has just opened up huge amount of doors for what my research capacity is and bringing in technology that I otherwise wouldn't be able to do by myself. So collaborations can be a very creative and fun thing to start and get into. And I just think indirectly about things, that there could be resources to you that just getting a little outside your shell could make all the difference for your patients. I'd like to give an example. I called Bradley Greger at ASU, and he made a pair of glasses that one of my patients who could only look up and down because of their special locked-in syndrome in the ICU, and she was able to communicate with her family because they made that special pair of glasses for her, because otherwise it's all horizontal, as you know, from locked in. So, I mean, it's so fun, I think. I mean, sad for the patient, but she was able to communicate then after. So anyway, that there could be other resources besides other doctors like yourself, and really thinking of yourself as a local leader and bridging those collaborations, which doesn't take a K award.
Yeah, thank you for that perspective. I think one of the questions I've always been thinking about is, you know, in training, obviously you want to go to places that have established mentorship and established pediatric neuro care, if that's the field you're interested in. But then after fellowship, kind of trying to, especially as you go to the job markets, you know, jobs might be limited, and you might end up at a place that doesn't have established neuro care, pediatric neuro care. So I was wondering if any of you had comments about making that jump and making that transition to joining a group that doesn't have established program and building something from scratch.
I've done it twice. It's a lot of work, but it's a lot of fun. I would say that it's very important to establish relationships across the departments with neuroradiology, with neurosurgery, and all the cultural differences between these different departments and nuances at different institutions is part, of course, the challenge no matter where you work, but most especially if you're creating a new program somewhere, and having the buy-in and goodwill from the other departments is absolutely critical. And sometimes even just really being proactive about your communication with the department leads and other researchers in those departments, and having face-to-face meetings with them, I guess, or Zoom meetings, with however you can, and familiarizing yourself with them and becoming a personal colleague to them can really integrate your goals and wishes of your up-and-coming program with what they need on their side, and make sure that your department is being helpful to them and a good neighbor.
Yeah,
I'm sorry, go ahead.
It's okay. No, I just going to agree with what Verena said. I had been doing a lot of neurocritical care, but when I moved to Hopkins, we definitely didn't have an official program, and Sujatha Kannan and I got asked to start it with no funds. Nobody gives you funds to start the program. They just say, start this program. And one of the best things we did, which looking back now was really smart, was just what Verena said, go and meet with each stakeholder, met with the head of pediatric neuroradiology, the head of pediatric neurosurgery, the head of the Kennedy Krieger Pediatric Rehab Hospital that's adjacent to us, so if you have some rehab folks. And we got buy-in from all those folks, and they were excited about the program. We made them key stakeholders in the program. And then we started a weekly case conference. We started a Thursday afternoon, 2 p.m., discuss the most interesting 3 to 4 patients, because you can do that for free too. And it got everybody together in one room to come discuss it. Our rehab folks were coming, talking about the patients that came, and it just blossomed from there. So those are 2 free things you can do if you're starting a program, is go around, meet everybody, become good colleagues and friends with them and collaborators with them, like Verena said, and then start something that helps you start to communicate and see each other regularly, which for us was focus on the patients, have a cool case conference. So it's fun.
Yeah, and I would just, again, echoing both those points, I'm still in it, so I can't say if I'm successful yet, but at least to start basic. You know, it's hard to start when people aren't sensitized to things, and you come in and, you know, you want to implement multimodality monitoring and things like that, and unimodality monitoring is barely already in place. It's not the way to go, so start really basic. As usual, get buy-in from stakeholders, including the bedside nurses, because once you get buy-in on that side, things roll a lot more smoothly.
Yeah, we were actually able to argue for protected time for one of our nurse practitioners to, and I know Mark's had a big role in lots of advanced practice nursing involved in his neurocritical care program too, but that was really key. We were able to get 1 day a week from one of our really junior but very enthusiastic NPs to help bridge that liaison, and then we've got some nice PICU nurse leaders too, and that's been very, very helpful also.
Yeah, I agree with all of that. I'll just add briefly that the interpersonal interactions are really important. Part of it, the case conferences are also helpful because people like learning about different organ systems and sharing, being enthusiastic and sharing things that you learn, because there's so much to learn in this field, and meeting enthusiasm with enthusiasm and shared learning goes a long way. It's not just about technology. Very little of it's about technology.
I would say the basic mantra is prioritize communication. You just can't underestimate it.
Can I add something too? I learned late in the game that having a nurse practitioner was a game changer. And I think if I was going to advocate for anything up front, it would be to have nurse practitioners as part of your program. And part of the reason for that is that they provide the continuity. So if you have these trainees that are coming and going, you're not constantly redoing the same initial course over and over and over again, where you're sort of talking about like the starter of status and what are the meds. You know, they can help you with the education piece, but they can also sort of provide the framework where this is how we do things, and kind of keep the continuity so that when you have strong fellows and weak fellows, the program kind of runs the same no matter who's rotating through.
I might just ask the group, do your nurse practitioners work outside of business hours Monday through Friday? Ours do not.
Ours do.
Oh.
Ours do.
Ours work 7 days a week, day shift, but they're going to nights soon too.
And do they take call? I guess your guys, that's what we're.
In neurology, they don't, but on other services, they do.
Yeah, these are the PICU-based NPs that I'm talking about.
Our neurocritical care APNs, we have two, just do Monday through Friday business hours, but the PICU ones have a schedule like a resident would, so day, night, weekends.
We have 2 nurse practitioners. They do Monday through Friday, and they do 12-hour shifts.
Do the neurological nurse practitioners, I'm sorry to ask this question, but it's just dying. When they take call, is there an attending also on call over them?
Our APP for neurocritical care doesn't take overnight call. Our APPs in neurology, the take call are for the epilepsy monitoring unit.
Okay, we're nearing top of the hour, so I want to open the discussion to anyone. If you have any burning questions, anything else you want to add. I know we discussed many topics in the last hour, from early career research to balancing your duties, then discussing, how you perhaps build a program or start a new program at a new institution. So I was wondering if there were any other topics that the trainees who are present on the call or any other faculty members wanted to ask.
One thing that I would say to the trainees on the call is you can get a sense from hearing all the different faculty members talk that the models are very different at different hospitals, and the models all work well for individual institutions. Some are more ICU driven, some are more neurology driven, some are more combination. And so I encourage you, when you're considering this path, to really apply to a lot of different programs and look at a lot of different institutions to one, just sort of see what's out there, meet the people in the field, but also see what model is sort of going to fit your personality and the mentors that you think you want to model your career after. Because as you can see, there's no one way to do this. This is a field with many people who have come to the field from all different backgrounds and all different paths of training. And we're going to continue to welcome people from different paths of training and who have different career paths going forward. So I just encourage you, even if you want to stay at your own institution and you've seen the model at your own institution, to take the opportunity while you're applying for various fellowship programs to really see what happens at other institutions and how neurocritical care is structured at different places around the country, because it can be very eye-opening.
And I'll just add to Matt's comment, because it is so different. I mean, I think the 6 of us that are on the panel here all have slightly different experiences and came from different eras of training, but I think we'd all also be very open to any help we could give anyone. So for trainees that are there, if there's any way any of us can help you with either program development or research-based K advice, whatever we can help with, I think Anna will have all our contact information, but you can always reach out to any of us.
Also, not be afraid to research what other people are doing. So when you go to a chief or a chair, it's always good to be armed with what package have other people been hired with. So if you go and say that other centers are hiring people and not making them do outpatient time, or they are making them do EG stuff, I think it's always good to know what other big centers are doing, because if you go in there and they're not used to the model of neurocritical care, they may have in their mind that you're going to solve their open access problem, but really that's not what you have in mind at all. So I think going in knowing what other centers are currently offering is also very helpful.
How would you find that out?
Yes, exactly.
There are lots of different ways to network. I think this panel is a starting place, but there are also other people that you've trained with that have trained with other people, and as much as possible, I would try and have an open and frank discussion. People are always sometimes hesitant to talk about money, but I think it may be a little bit more comfortable to just talk about what is your percent time and how is your year divided up, and what are your core responsibilities with or without research funding. I probably wouldn't limit those questions to people that are just being hired. I would also sort of figure out what the mid-level and the senior people are doing, just so you can kind of have an understanding of what the spectrum is.
I think it's totally a fair question to email a chair or a director and ask, do your new hires ever have opportunities for protected time, and if so, under what conditions? I think that that's a totally fair question, and definitely something that should be asked before you get hired on somewhere and you find out it's not the case.
So I can tell you, as the person who would be answering some of those questions, I would not be at all offended if somebody asked me, as Marina said, you need to be both sides, a person being hired and a person group doing the hiring. You need to have a shared understanding of what the objectives of that position are. So getting the right resources and establishing those expectations is really key. Those are completely appropriate questions.
Great, fantastic. Thank you all so much. So as I mentioned, I do have a database of trainees, some of who were not able to join today. I think it's week for boards, both for neurology and I think Canadian critical care. So a lot of them are currently taking exams. If it's okay with you guys, I would like to share some of your information, contact information, in case trainees would like to connect with you as mentors or ask questions about the next stages of their career. I'm so thankful for all of you and your time that you've given this morning.